If you were on a deserted island for the rest of your life, but somehow your patients kept coming to see you, you could only have the ability to get three labs. What do you think are the most important labs to be able to obtain?
Ooh, great question.
Somebody get this guy some help!
Or, put more simply,
If you need help like this guy, call your own doctor.
Um, if I'm picking like singular labs on like a LabCorp Quest requisition, that's harder. I would say like a comprehensive metabolic panel and a complete blood count. So those two are just non-negotiable. Um,
Let's say
third,
you have the basic labs and we're talking about
like specialty.
more.
Got it. So let's say basic labs, and then I would do stool tests for sure. And there is so many good ones out there. Doctor's Data, Genova Diagnostics, GI Map, those are all kind of conventional. They do pancreatic enzymes and digestion and inflammation markers. Some of the newer ones do metabolomics, which is like the metabolites of the microbiome. That would be like the BiomeFX, the Jonah, there's three or four out there that are, so there's kind of different ones, but some sort of stool analysis for the microbiome. And then for sure, hands down, without a doubt, the organic acids. And it used to be Mosaic, now Vibrant does it, now Doctor's Data does. I think there's multiple companies that do that now as well. But organic acids is one of the things I love the most. I feel like it provides incredible data.
The inflammatory markers on the stool test, are those better for any reason than things like CRP and ESR, the inflammatory markers that you'd get out of somebody's blood?
Yeah, so basically, and I've taught GI for physicians for years. That's how to test. So there's this acronym DIG, DIG. Digestion absorption is the first thing, and we look at things like pancreatic enzyme, protein in the stool, and basically what we're looking at is your pancreas and your stomach acid breaking down the food, because that's a first precursor. If you don't do that, you're going to inevitably have overgrowth of bacteria in the small bowel or overgrowth of fungus in the small bowel. So that assesses digestion. I is inflammation, and there's a lot of markers on different tests. Calprotectin is a big one. And that one, if it's above 200, you can almost guarantee there's some inflammatory process. You need to get a scope. You need to rule out Crohn's, colitis, cancer. But if it's less than 50, you can almost 99% certainty know that you're not missing cancer, Crohn's, or inflammatory bowel disease. So that's a really helpful marker. There's eosinophilic protein X, which is more the allergic or the parasitic component of an inflammation. So these are very different from CRP, because CRP is this non-specific inflammatory marker more related to heart attack, stroke risk, chronic infection, maybe a dental abscess, whereas the calprotectin and the eosinophilic protein X are very specific for, like, you can look up the differential, and calprotectin is going to be likely Crohn's or colitis or cancer or maybe acute gastritis, whereas eosinophilic protein X might be some sort of a leaky gut, post-infectious IBS. And then you have things like lactoferrin and SIGA, which is the gut immune system. And those are all super helpful to see what's going on in the gut. And it doesn't even, like, that's not even looking at the microbiome yet. That's just looking at digestion absorption. The reason that's important is because many people have dysbiosis in the colon or small intestinal bacterial or fungal overgrowth. And you can treat that all day long, but if you have a deficiency of breakdown of nutrients where you're not breaking down complete fats, proteins, carbohydrates, that will inevitably lead to recurrence of that dysbiosis. So you have to address all the parts.
Most patients across America are kind of prisoners to the medical system and the way that insurance operates. I can imagine that insurance probably is not going to be willing to cover a lot of these tests, creating kind of an exclusivity with this type of market. What do you think is the general kind of cost out of pocket, or have you had any success with insurance covering any of this?
Well, the great news is TRICARE, which is military, and Medicare are the best. Like those patients, I can get 100% coverage for like Genova diagnostics testing, which is really amazing. So, of course, those patients, I'm like, oh, this is great. We can do this all for free. And so I can do routine blood work. And there's certain companies that bill Medicare. And so I can get a lot of that done. The average patient with traditional insurance like me, it is usually cash. But nowadays, what you can do is often do the test, and I'll tell you kind of a range of prices, and then submit it to your insurance. And sometimes you can get reimbursed. And I find as I explain it to patients, and most of my patients have seen a lot of doctors, they've done a lot of things, and they're really like, I need to get well. I'll do whatever you say. And so they're willing. And what I found in my practice when I first started family medicine and everything was insurance based, my patients would be like, well, Dr. Jill, you want me to take vitamin D? Is that covered by insurance? And I was like, are you kidding me? A $5 bottle of vitamin D? Like, and then when I realized as people were starting to pay cash for services, there's a piece when you invest that puts you vested, right? It's really a powerful healer because if you're not invested in some way where you put your dollar where your mouth is, where you're like, I'm willing to put this in for my health, and it doesn't have to be thousands of dollars. I'm just talking a little bit of investment, whether it's paying the doctor or paying the lab test. When you're invested, you've put in money, so you're going to do the work that needs to be done. And I find that to be a really good motivator. And so for the average patient, say we do a stool test, organic acids, and lab test, it could be anywhere from $500 to $1,000. It could be more, it could be less, depending on coverage, but it is an investment into testing. But my patients mostly find they're really worth it. And I'm always like negotiating, okay, here's what I'd like to do. Here's what can you afford? So I will always be open to like doing less if they can't afford it. And honestly, for you and I, a good clinical history is the best diagnostic. So I can do a lot for free.
Absolutely. No, that's good to know. I'm certainly trying to incorporate more of this into my own practice because this system of psychiatry in particular is absolutely atrocious. I mean, in my opinion, medicine as a whole has kind of become increasingly robotic, with medical schools having this like infestation of pharmaceutical company propaganda kind of occultly embedded into curriculum and driving clinical guidelines that, as we've said, focus on acute disease treatment when the best treatment's absolutely prevention. Throughout medical school, I was taught that lithium was this toxic drug. And while it was really effective in bipolarity, it was just too damn difficult to use. And then during residency, soaking up as many podcasts, as many scholarly articles and papers as possible, trying to make sense of a nonsensical field where I was taught to prescribe SSRIs for everything from general anxiety to depression, whether it was major depression, not to be confused with minor depression, which doesn't exist, or bipolar depression, OCD, eating disorders. And again, even though it's known to potentially instigate mania or at its worst suicidality as a side effect, to still consider it in bipolar depression. Through the whole training process, I learned just how much more successful at a population level individuals with bipolar on lithium were. And it's not because lithium is good at treating acute manic or depressive episodes. It works as a prophylactic agent against those extreme swings in mood over weeks to months. It's also the only substance proven to reduce the risk of suicide, the worst outcome in psychiatry, with all kinds of additional medical benefits and risks that increasingly, I think it's being revealed, that have been significantly overstated. So I've had more success with that drug as a psychiatrist, not just in bipolar patients at higher doses, but also at much lower doses in conditions like depression, OCD, autism, PMDD, or what we used to call PMS, among others. And I've got 400 to 500 scholarly papers and articles. That's how I came across your work. I saw one of your articles on lithium and reached out to you after that. Tell me a little bit about your experience with utilizing lithium, where and how you learned about its benefits, overstated risks, and maybe what conditions you find it most useful for.
Yeah, gosh. So orthomolecular medicine, there was a teacher of this years and years ago, kind of in the functional realm, that started talking about lithium. And I really read the research probably 20 years ago. And I thought, oh my goodness, this is it. Because we think of it as a drug, and it is in higher doses. It's prescription for sure, but that's like 100 times the dose of what I typically use. So in clinical practice, I use 10 to 30 milligrams a day, which is lithium orate. It's available over the counter. There are some doctors that actually say we should put it in the water. It's so helpful, and we're so deficient and it's beneficial. But the thing that really tipped me over is understanding methylation and the power of methylation. We know this because prescription drugs like Deplin and some of these, there are 15 milligrams of methylfolate, are powerful in certain people with issues. And what I've seen is histamine and methylation and B vitamins are so critical to mood. For example, if we have excessive histamine, there is study after study after study that bipolar mania, schizophrenia can happen with just excess histamine. So you bring that histamine down. And some of these antipsychotics are actually antihistaminic, and that's how they have their effect. Then the methylation piece, if someone's not getting enough B12, methylfolate, B6, or riboflavin, which are all methylating factors, or they have a methylation defect where they require more, one thing I found fascinating is B12 is critical for mood, critical for energy. Like it's one of those most critical nutrients. It's water soluble, it's pretty safe. And a lot of times we see B12 deficiencies or subclinical B12 deficiencies. We give a patient B12 injection, sublingual, liquid, or a capsule, and all of a sudden their serum B12 will go really high. And what happens is in the serum, if you have an issue with transport of B12, there's a gene called TCN, and there's a couple others that can't get B12 into the cells. So what'll happen is you give them B12, it'll be in the serum, but it's not getting into the cell. So then the next doctor who checks is like, oh my gosh, your B12 is greater than 2000, stop the B12. It's not the B12, it's in the serum, but it's not getting into the cells. And lithium happens to transport B12 from the serum into the cells. I personally went through this, and I think part of my cancer, one more factor, was I had no idea I had pernicious anemia, severe B12 deficiency, and pretty much every genetic SNP, this is single nucleotide polymorphisms, these are abnormalities in how you process around B12, for me was abnormal. So I had a lot of hits against me for getting adequate B12. And I would always have that high serum level until I started on lithium. And it was a big game changer. So yes, lithium stabilizes mood. It has many, many other pleiotropic effects. But for me, one of the big ones that people don't realize is it helps to facilitate getting B12 and folate into the cells. And I find that so crucial for mental health. And once again, back to the dosing, if you're doing 5, 10 milligrams, even up to 30 per day, I still have yet to have anyone who's had a side effect or a problem with those levels. Like never have I had any reaction. It either doesn't work, which is rare, or it works, but I literally have had zero side effects or reactions with nutritional dosing. So super safe, even for children, like above 8. I don't do the little kiddos, but even for young people, it's very effective, very safe.
I've had a very similar experience in terms of risk profile when I use supplementation or even the lowest doses of lithium carbonate, 150 or 300 milligrams. I'm looking for
Yeah.
abnormalities on labs. I'm looking for hypothyroidism. I had one patient whose calcium shot up to 10 and a half or something. And I thought, oh, I've created a hyperparathyroid state, and went back a couple of weeks later and the calcium was absolutely normal. The risks of that are so overstated. And I think that the majority of risk associated with lithium could be ascribed to so many other things that we would not ascribe any risk to.
Right.
It has to do with brushing up against toxicity, which is actually how we kind of created this idea of a therapeutic level as we push people with bipolar disorder up until they got these side effects that indicated toxicity. And then we dropped the dose down a little bit. And it speaks to something that I think is so important in all of medicine, is talking to our patients and educating them on the length of time and how appropriate treatments should work. For me, I don't want my patient to feel like a different person,
Right.
to feel this psychoactive change. It's like I have a dirty river and I can connect a hose to that river and put it through a purifier, and I can purify every cubic gallon of water or cubic liter of water in that river and then dump it back in. If I could do it fast and efficient, it's going to be obvious I'm in a very clean river compared to just being in a dirty one. The alternative is to go upstream, find the source of the pollution, put an end to it. And if I go right back downstream, the water's going to remain dirty until that pollution works its way out. But one day I'm going to be standing there, I'm going to look down and I'm going to say, wow, I can see the bottom of the river all of a sudden. I can see my feet. How do you counsel patients? It may be a little bit different because I'm working in psychiatry, and in a way, our field has kind of programmed patients to anticipate a psychoactive response as evidence of whether or not that thing is working. So I've got to do a lot of psychoeducation with what I do, but how do you counsel patients on how to notice the impacts of some of these really kind of silent treatments, essentially?
Oh, I love that because it really does start. There's like your river analogy. Even when I'm doing, whether it's a psychiatric diagnosis or a medical metabolic syndrome or diabetes or whatever, just like the patient is like, well, is vitamin D covered? People are so programmed to have a quick fix and to expect this turnaround within days or within weeks or maximum 4 weeks, right? So the education is huge. And I find it's those daily habits. Usually, when someone's in that depression or struggling, part of that affects their ability to make good choices and habits. And what you and I need is for them to get out and move and exercise. The data on exercise and depression is better than any drug, right? Like it's profound. So like I
And it
always,
builds and it
yeah,
builds and it
yeah.
builds over time.
But can you imagine someone who's in bed, totally depressed? How do you get them out of bed and moving? So you have to start with these manageable, little tiny, it might be like going to the door and looking out the window. It might be, and then going back to bed. I remember the first, kind of functional person I had years ago, it was probably right through residency. And it was like he was drinking 2 2-liter things of Diet Coke a day or something like that. And I remember thinking, okay, if I ask him to go on an elimination diet, get rid of gluten, there's no way. So I said, let's decrease Coke consumption by like 25%. Well, he came back in a month. He had lost 20 pounds. He felt better and he'd actually gotten rid of all the Coke. But that was the only thing he did. But it was like this thing that was kind of, it was hard, but it was one small step. So when it comes to clean air, clean water, clean food, movement, eating clean, avoiding toxicity, avoiding chemicals, eating all organic, get rid of your air fresheners, those chemicals and all these things, right? Take the stairs instead of the car. It is totally overwhelming for someone with a psychiatric diagnosis. You have to put it in bite-sized pieces. And then you have to create a new identity because once that person believes I am a healthy person, I have a happy mood or whatever kind of thing they're dealing with, they have to start to believe that's their new identity. Because when it's an identity versus just a habit that you have to do, like stop watching TV, get off the couch, go exercise, versus I am a healthy person. What does a healthy person do? Oh, I wouldn't be sitting on the couch and drinking Coke. And so you switch identity, but you have to really be with them. And it starts even before that, because when they come into our offices, if our body doesn't feel safe, we can't heal. So it actually starts way, way before any advice is given in creating a safe container for that patient to feel like we really genuinely care. And I know you and I do, and that we want to listen and help them, and that we're partnering, that we're not this paternalistic boss that's going to tell them what to do. We're negotiating with where are you at? Where do you want to go? I always like to find in the first visit, what's the thing that matters? It might be someone who says, I can't walk with my grandkids because I don't have mobility. It might be someone who says, I can't get out of bed and cook dinner for my son. Whatever it is, you want to find out what matters to them and then work reverse engineering around how can my treatment help you do what you want to do more of? Because if we just say, well, I want your mood to be better, or I want your A1C to be 5.4 instead of 5.8, they don't care about that metric. So we have to engage them in a partnership in what matters to them. And I want on that very first visit, something that I do or say to change them enough to where they're like, oh, I feel better, right?
You sound like you're speaking from an acceptance and commitment therapy perspective. I'm coming out to Denver next month to do, well, really my first conference since I got out of training, and I'm going to a therapy conference. Just
Awesome. Yeah, it's so
and
important, right? Because it's a like,
it's so, and what you're talking about is connecting the person's values, aka what matters to them, to the reason why the goal even
yeah,
matters at all. I just love the way that you said that. We set all these lofty goals, but so often we lose sight of why we care to meet the goal. And so if we fall off the wagon one day, it's like, well, I had 45 days of sobriety and then I drank. And so, I'm back to day one. It's like, no, you've had 45 days of living by what you care about and what's important to you. And just because you spent one day not doing that, it doesn't change the fact that the next day, that same value is going to be important. It's going to provide meaning in your life. And when you connect people with that, it just makes the job so much easier too. Do you have any background in ACT, or are you familiar with it?
I have heard of it. Yeah. And a lot of it's just over the many, many years. I happen to be a very intuitive, emotional empath. And what's funny, I'll talk about that real quickly because all of us going to medical school, we're trained in the analytical mind, right? A scientific method, which is great. Like we need that foundation. I was an engineer background. But what I found in my 20 years of practice that was probably the most powerful thing was the combination of science, analytical mind, plus intuition. And that intuition is just sitting with a patient, being with them, listening to them. We as physicians get told that there's no value in that intuitive sense, but the truth is there's a great value, especially once you have wisdom of experience, because you start to see patterns and you recognize a pattern that you saw before, and then you prove it with science. But I just like, whether you're a patient or you're a physician, combining science and intuition, faith and science, any of these kinds of things where they're two different dichotomous things, it actually provides a much richer experience and much more wisdom in the treatment.
You have to find an openness when you're in those rooms, when you're in those situations, because for myself, and I talk with my patients about this a lot, when we're consciously searching, seeking for the answer, it's so much harder to find as opposed to us being in our present moment, receiving openly as much information or the nonverbal kind of expression of the patient. And our minds are so much more powerful than the conscious parts of us. And it's that kind of interaction between the two that I think creates a really powerful brain that can figure things out. It's actually the way that I try to explain mental illness to my patients is just this kind of back to the drawing board of how do I interact with my mind? Let's start there because every human being can relate to that as opposed to, talking about different regions of the brain being implicated as causative factors or it's all biologic. I know you've only got a couple of minutes, but I've got one other question in that kind of vein of thought. I like to think of views on psychiatry in particular in terms of this pendulum. There are extremes on one side that state everything can be cured with lifestyle modification, change in diet, activity, mindset. And the other extreme promoted by big pharma and big hospital is that everything's biologically based and requires a biologic treatment. I certainly think with where we're at right now, the bigger problem in healthcare and with Americans' health in particular is the latter. And don't get me wrong, diet and lifestyle interventions are so underutilized and can absolutely move mountains in terms of outcomes. But I'm curious to hear your take as an MD who's gone through the entirety of the US training system. Where do you think the appropriate middle ground is between these kind of polarizing philosophies?
Yes, I love that because I'm one who can see all sides of every issue. So, what I think is if you break a leg and you need to have that set, and then you need a crutch, you need a crutch for 6 to 8 weeks while it heals, and then you throw that crutch away and you do rehab or physical therapy, and all of a sudden you get your strength back. So over the next 4 months, you're back to your normal self, maybe 6 months. It is very often that we need a crutch, and pharmaceutical medications can be crutches. There's nothing wrong with that. Like we couldn't stand up without a crutch with a broken leg. And often with functional medicine, whether you're going to the gut microbiome, you're going to diet, lifestyle, nutrition, nutrient deficiencies like lithium or B12 or methylfolate, or any number of things, those things will take time. And sometimes someone is in a crisis and they don't have time. They are suicidal, they're at risk to themselves or harm to others, and you must intervene and you must give them a crutch while you go to the root cause and fix that broken leg. And same thing with Crohn's disease. I treat a lot of Crohn's because I've had it. So I have people come in a crisis where they're not absorbing food. They're, very, very, very sick and they want to avoid biological drugs. Very frequently, if they need it, I'm like, let's get you on that biological drug. I don't love them. I prefer to not have them on that, but it's a crutch that will help them because I know that when I look at the microbiome and try to heal the gut, it's going to take 8 weeks, 12 weeks or longer. And the same with healing the mind and the brain. And it's all related to the body. The brain is not separate as you and I started our conversation. So most of the time, functional interventions take time. And they're powerful and they can reverse disease completely. As in my case with Crohn's, I no longer have Crohn's. But I would say I worked for 2 years on my gut to get it to a state where I was 80% healed. And then over the next several years, maybe at 5 years, I was 100% healed. That's a lot of years if I was really, really sick. So I think it's this thing of like thinking of it as a broken leg, putting a crutch on board while we're healing and using those things as appropriate so that we can go to the root cause and reverse that process and give it the time it needs to do the right thing.
Do you think that lithium's GSK-3 beta activity and its ability to chronically decrease inflammation, do you think that is helpful in Crohn's?
Yes, yes. And that's the thing. A lot of these things that we see like work for depression. Well, IL-6, for example, if you look at the studies of IL-6 and depression, there's thousands of studies that show this cytokine reaction to depression. Those same cytokines cause autoimmune disease, inflammation, Crohn's. And it's no wonder that people with Crohn's or colitis have a higher risk of depression because when there's inflammatory cytokines, it can affect the brain and the body, or the microbiome might be affecting the brain. So to me, this all works together. And that's why you can see things like lithium treat multiple conditions, not just mood disorders.
There's a guy in New York, Sadir Gad, who's a big proponent of low dose lithium, who did a really interesting study in COVID, bipolar patients on lithium and not on lithium, and measuring a bunch of interleukins over their hospitalization and just showing the inflammation was significantly reduced and the immune reaction to COVID was reduced across 18 different inflammatory markers. Not to mention the outcomes of this admittedly smaller study were 14 patients in each group, and two of the non-lithium treated patients ended up dying and several in the ICU, and none of the lithium treated patients were hospitalized for longer than a week. Nobody in the ICU, no deaths.
Amazing.
So, gosh, I got so many other questions I want to ask you, but I know that you are in a bit of a time crunch. Any other things that you want to mention or that you think it's important for just the general public to know?
Yeah, if you're a doctor listening, maintain curiosity. It's the best thing. And if you think about your guy behind you, Einstein, he would always say curiosity is a mark of genius. And I love that so much because one of the things that probably has helped me most, humility and curiosity. I don't ever pretend to know everything. And so often my patients teach me something in the process. So if you're a practitioner, just remember humbleness and curiosity. If you're a patient, remember hope, because no matter where you're at, what you're struggling from, what you're dealing with, I have yet to find a patient where I can't move them to a different realm of how they're doing. And it may be small steps, but there's always, always, always hope in these situations. So that's what I leave people with.
Awesome. Well, thank you so much for coming on. I appreciate it. It's been wonderful talking to you and this is my continuing medical education. Nobody really watches my podcast or listens to it, but I love it because I get to learn things that I didn't learn in training, and I get to expand my arsenal and just continue to chase curiosity. So I would love to sit down and talk more. If you ever have time in the future, let me know.
Love it. And I couldn't agree more. And thanks for having me on.
Absolutely.
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment. Or, put more simply,
If you need help like this guy, call your own doctor.
Thanks again for watching and or listening. If you're passionate about the subjects that I discuss on the channel, do me a favor and like, comment, subscribe, do whatever you can to make your voice heard, that these are problems that must be addressed in our society. If you have any questions, comments, or concerns, I want to hear them. Feel free to reach out on social media or email us at renegadepsych@gmail.com. And if you'd like to be a guest of the show or you have a connection to somebody that you think would be a good guest, let us know. Thanks again for listening.